So I'm Barbara Fain. I know many of you, but not all of you. It is wonderful to see you here. I'm the executive director of the Betsy Lehman Center, and I'm really thrilled to open what is now our 10th annual care forum, which is a pretty significant milestone in and of itself. It's also, just want to note that it's the first forum with an in-person, the ability to gather in person since the start of the pandemic. So we really want to welcome all of you who came in today. You never know. We do these in-person events with a hybrid option, and you just never know if anyone will show up in person. So thank you for those who made the trip into Boston, and welcome also to the many of you. Do we know approximately how many? There are a couple of hundred people signed up to join us remotely. So welcome to all of you as well. So a lot, as you know, has been accomplished on transparency, improvement, and reconciliation since M.P.H was born over a decade ago, and its programs, resources have played a really significant role in pushing this critical work forward in Massachusetts. I'm also pleased to report that as of this year, the M.P.H program, what we now call CARE, has been fully absorbed into the Betsy Lehman Center. And we've already seen the benefits of this integration. It makes it easier to implement CARE in more places and to bring everyone together, and to and also to bring you helpful content in formats that are easy to use, like the resources and simulations that we're going to be sharing with you today. I also just want to note, without going into any great detail, because we can talk about this all day, that we've made CARE an integral strategy of the state's new roadmap to healthcare safety, and which is really going to, I think it is integral because it's just so much. If we really want to drive big improvement on safety, we need CARE and similar work to be part of that. And it also, by making it central to the roadmap, it's actually going to advance CARE. I'm hearing an echo. Should we maybe turn it back down? Okay. So I am in a second after Melinda lowers the desk better, I think. Is this better? Okay, great. I'm going to turn things over to Melinda Van Niel, who's CARE's program director at the Betsy Lehman Center now, and I think since its inception. Were you there at the very beginning? You were there at the very beginning. And also just want to, as an aside, recognize that when we made the decision to bring M.P.H under our umbrella, we wouldn't have done that unless we knew we were bringing Melinda as part of it. And also the M.P.H board, which has become our advisory board, which is really allowing us to continue this work. So just want to say a huge thank you to Melinda and all of our board members. So Melinda's going to get started with just a brief introduction to CARE for those of you who may be newer to the concept. She's also here to update you on the many new resources and other work we've been doing over the past year.
Great, thank you, Barbara. And thank you all so much for coming. We're really, really happy that you're here today. So as Barbara said, we have 160 now people online. So there are a lot of people joining us today that may not know a lot about CARE. And I also think it's good for us all to make sure we're on the same page about why we're here, what are we doing, what are the important components of CARE. So these are the objectives today, and you all have received this disclosure and CME information in your packet. To get that CME credit, you will need to fill out an evaluation, which is going to be coming to you in 2 weeks, hopefully less. But please be on the lookout for that. You will have to fill out that evaluation, then you will get your CME certificate. If you need nursing credit, once you get that certificate, just email it to me and we can convert that for you. Okay, so today we have a lot of exciting things on the agenda. As I said, I'm going to introduce sort of the topic and what we have been doing for the past year here at the Betsy Lehman Center for Care. We also have some wonderful simulations here today. We've always heard from our audiences and those that are implementing care that seeing it in action, watching what you need to say, seeing people really do this in real time is something that is really valuable. So we've created a new scenario for you today, and it will also be part of our simulation library that you can access later. Then we will have some panels discussing resolution conversations for those who have a lot of experience in this. After that, we will talk about care support. That is a framework for what a lot of you will probably know as service recovery. But in the context of care, there are some challenges around that. And so we're going to have a presentation about one site that does this, and then a panel of a lot of different sites and how they approach service recovery, which we call care support in this model. After that, we will have a provider testimonial, a provider that's been involved in a care resolution, and he's going to talk about his experience and some lessons that he's learned. And that will be our day today. So we're looking forward to it. Okay. So, get this set up here. All right, so for those of you who are new to this concept or maybe need a refresher, we wanted to just make sure that everyone knew what do we mean when we talk about communication, apology, and resolution. There are several components, so it's not just being transparent with patients or resolving cases where you know something has gone wrong proactively. It really is a systemic, pattern that we want to make sure that is rigorous for every case, every time that we see in patient safety and quality as an adverse event. So the first piece is to communicate, of course. So communicate proactively with patients and families about adverse events. And what that means is we want to tell them, even if they wouldn't know already, if it was something that you would want to know as a patient or a family member, or if it's something that affects that patient's care now or in the future, they need to know about it and they deserve to know about it. And that's a really important part of this program. Then you connect them with team members who can help them throughout the care process. Again, we'll talk more about that care support piece. Apology is a really important piece as well. Expressing empathy, expressing that apology that we are so sorry that this happened is another really important component. Nationally, that's sort of been dropped from the name. CRP, you may have heard of, or CAND, things like that. And those programs all are basically the same as care, but I think here in Massachusetts, we really want to emphasize communication, apology, and resolution, because it is a really important component that patients and families hear that we are sorry that something has not gone the way that they expected. Then, of course, we investigate, and that's what we do with all adverse events, but we investigate with an eye toward how are we going to explain to the patient what has happened and how are we going to fix that for future patients. It's really important to develop those corrective actions in a way that we can be held accountable to these patients and families. Then we move toward healing. And so what that means is resolution conversations. And you have resolution conversations in all of these cases, even cases where you have met the standard of care and there was just a complication. Because when we have cases that indicate to us that a patient hasn't gotten what they need, we want to make sure they get extra communication around that. So even if it's something that, you know, the physician involved said, well, this is a known complication. If that patient comes to us and doesn't understand that, it's our job to make sure that we support them in understanding that and help them get connected to the resources they need. And then for cases where we feel that we did not meet the standard of care and that caused significant harm to the patient, we proactively move that to resolution with the insurer. So that can be in a captive model, you know, you might just move that over to claims, or in a model where you have an external insurer, you work with that external insurer to have them connect with the patient and analyze that case for potential compensation. And again, that's a proactive thing that we are doing as part of this program. We know it's met the criteria and we want to move it forward, because a lot of patients don't realize that that's something that they deserve or need for that kind of adverse event. So that's an important piece. And then, of course, resolve. So we will resolve those cases that deserve compensation outside of court if possible. And then we ensure that the safety improvements are made, which is a really big component of this, right? The whole point is to prevent this from happening to more patients over time. And that will help all of your future patients and your facilities as well. So that's, you know, the basics of what we mean for the program. Why do we do this though? And I think it's always really important to sort of help us get back to the basics of why is this important for everyone involved in the healthcare system. So we know now, we have some evidence from the Betsy Lehman Center as well, that this is better for patients. So they are treated with compassion and honesty is what you would want if it happened to you, right? We can get the answers to them that they are looking for and get them the support they need. And it's a fairer and more timely process than the court system, right? For providers, it preserves that patient-provider relationship that, is so important and that is really destroyed in a lawsuit, right? It's something that we want to be able to perpetuate over time, even when something goes wrong. And so this gives us the best chance of being able to do that. They can also express their natural empathy and get the support that they need as providers, because it is certainly something that affects providers as well. We know that very well. And the Betsy Lehman Center offers some peer support around that as well, because we know that when something goes wrong, providers feel, a lot of emotions and they need support for that as well. And the true systemic causes are more likely to be unearthed if you use this kind of a program, right? We don't want to blame individual providers for system errors. And this kind of approach really tries to focus our attention on what systemic problems have happened. And if that case goes to compensation, there's the ability to say this was a systemic problem, rather than going to court where here in Massachusetts, the physicians are the deep pockets because of charitable immunity. So they often focus on the physicians individually for themselves, and that is really not often the case why those things have happened. Really, it is often systemic problems. So this helps us to refocus our efforts on that. And then it's better for the healthcare system. So there's less defensive medicine, the system improvements are made, and then it builds trust in a system where the providers that are involved there feel like they can report events and that they will be supported. There's a just culture around that. And so this is the adverse event pathway for care. So on our website, we have algorithms that really detail every single step, but this is just sort of a basic overall view of what do we do and how are we looking at cases. It's really important that we do this on every case, every time, right? We want to go through these steps for each case. So when something happens, we respond immediately to the patient's clinical needs, communicate proactively, express empathy, investigate, make changes to improve, and then inform the patient of those changes. No matter what, any kind of care case, those things should happen. And then when we're looking at what actually happens after that, there are different ways to resolve these cases. Most of the time, and you can see here it says 85% of the time, that's based on data from our pilot study that was done from 2012 to 2015. Most of the time, you're going to be in the area where when you investigate this, the standard of care was met. And that may have caused low-level harm or may have caused high-level harm, but you're in the bucket where you feel like you're in the goalposts. You have delivered care that meets those standards that you have. But these patients still need a resolution conversation. So you can see here, even with that 85%, you explain what happened and answer that patient's questions, continue to express empathy, and then there's the option of care support even for those patients. On the other side, we have about 15% of the time cases where you feel like the standard of care was not met and that caused significant harm, or you might be unsure, right? You might not know if you met the standard of care, or you might not know if it caused the harm. You might have conflicting reviews in your internal process. And so there are lots of options there, but all of those point to what we would call a care insurer case. And that means that you coordinate with your insurer, explain what happened to the family again, formally apologize, and then proactively offer compensation if applicable. If you're in the scenario where you're unsure, your insurer can really help you figure out how to phrase that for the patient, that we are unsure. We'd like to have our insurer take a look at this, have some more expert reviews, get some more in-depth feedback on what has happened and how we can help you. So those are all the different ways that we can handle care cases. But a lot of folks say, this makes sense to me. This is what I would want, but is it going to be good for my facility? Should I be worried about the outcomes? And this study that we did from those 3 years, 2012 to 2015, said, really was supportive of using this. But since then, there has been lots and lots of research that has only compounded the benefits of this. And so what we know is that we can do this rigorously and claims and costs do not increase. And in many cases, they decrease. So for the people that are worried about the financial situation, this really shouldn't be a worry anymore. We have been able to demonstrate that here and in a lot of other models around the country. And some have even actually seen even more financial benefits. Providers, we know, are also supportive of the program. They overwhelmingly, when involved in something like this, especially those who have to have those resolution conversations with patients, feel really positively about how it has gone. And you'll hear today from a provider who has experienced that as well. Patients are supportive of the program. So when they are involved, they feel that this is a much better way to resolve something that has happened to them. And they don't always feel like, you know, it has been completely resolved, but they feel like having been listened to and having been taken seriously, that they are able to take a step toward reconciliation. And so that's really important. We also know from data that has been released from the Betsy Lehman Center, and you probably all of you in this room have seen this, but that patients who don't receive the components of communication, apology, and resolution when they have an adverse event have really long-term negative impacts. And we'll show you that slide here. You can see that especially the avoiding a facility, avoiding the doctor feeling angry, really big difference between the orange, which is having an adverse event without open communication, versus the blue, which is having open communication around your adverse events. So you can see there's a really big difference here. And so it's really important to everyone involved that we take this kind of approach, but it is a rigorous program. And so I know that the philosophy is something that most people today feel pretty comfortable with, that this is what they would want and it's the right thing to do, but it does need to be a rigorous program. And the reason for that is that you can't realize all the benefits of care if you're not doing it every case, every time. The algorithms need to be applied, which means that you're keeping track of when you're contacting patients. When is the last time you talked with them? Have we gotten a review? How long has it been? Do we have all of those reviews from each department that we need? It's a lot to keep track of. And it's a little bit different than probably what somebody who's not implementing care does right now. I've heard from a lot of facilities that we implement with that they intend to do this, but a lot of things fall through the cracks. And so implementing in a rigorous program like the Betsy Lehman Center has really helps you to be able to make sure that all of your patients are getting equitable treatment in this way. And we also ask that they report data. So it's really helpful for them to see how's my data being compared over time for my own site and then to comparator sites. So in the Betsy Lehman Center, we will match them with another site that is about the same size and about the same area. So they can see, you know, what does their caseload look like? How did their cases shake out? And then they can use that as a barometer for the health of their own program. So I want to talk just for a few minutes about what the Betsy Lehman Center actually does for communication, apology, and resolution in the state of Massachusetts. The first thing that we do is care implementation assistance. That's our main sort of project that we have, is to try to help all sites in Massachusetts get a rigorous program up and running. And so we have implementation consultants that go into your facility and help you figure out how to sort of overlay this on your adverse event process already, make sure you're doing it every case, every time, and joining the Betsy Lehman Center board so that you can report your data, join the discussion sessions, and get that information back to you. So that's the first thing. The other thing that we do is we develop and publish new resources around this. And this is such an evolving field that we basically can develop them in real time. So what happens is as we're implementing, we may have different cases or challenges that come up. We bring those up in our discussion groups. And then we say, you know, it would be really helpful if we had a resource around this. So I'll show you today a few of the resources that were developed this year. But what's nice is that there is a group of all different stakeholders in this kind of process, so that we the Mass Medical Society, the Mass Bar Association, patient groups, all the sites, the insurers get together and meet around these resources. And so when we publish something, it's something that has been supported and seen and edited by all of those. So when we publish that, you know that all the stakeholders have seen it and are supportive of it. So that's one really big piece of what we do with our time. We also have now some simulations, some that you'll see today, but we have a simulation library, and that's also content that's been created here as well. We also do data analysis, like I said. So we have outcome measures required from each site, and we analyze and give them comparative data, and that's reported back to them with a summary of what that looks like and some recommendations every year. We also have discussion sessions, and those have been extremely valuable for the sites that are involved in communication, apology, and resolution now. So we have those that have been doing it for 10 years with those who are just implementing now, big academic medical centers, smaller community hospitals, all meeting together to discuss challenges. Sometimes they'll have a particularly hard case. Sometimes they'll have a situation where they have, I don't know, multiple insurers involved or something like that. And what we're able to do is talk to one another. Have you had this experience? What did you do? Do we need a resource around this? And that kind of thing. So it's been really helpful to those sites to be able to talk through those things as they're implementing. And even as they've been doing this for a long time, sometimes there are just new challenges that pop up. So it's been really helpful. And finally, we're a voice for change. So we have a lot of our members around the state and around the country advocate for this kind of program. And so we have helped out in a number of national efforts. You know, the Candor Toolkit was something that some of our board members looked at and helped approve. And there are many other efforts around the country that are going on now that we help with. So it's really, we see as part of our mission here in the state to try to make this a reality for all adverse events, but we also feel like it's our responsibility to be a voice for that around the country as well. So in this past year, we have 13 Massachusetts sites that have official care programs with the Betsy Lehman Center. We have 2 new sites this year and 2 more that should be up and running by the end of 2023. So that's really exciting. We have 2 more expected in 2024 with others that will be implementing that hopefully will be done by the end of the year or a little bit after that. So we are certainly growing, and I do think that there is sort of a catalyst now that everyone is saying, you know, this is something that I'm hearing a lot about. I know a lot of other sites in Massachusetts are doing this, and around the country there are, you know, around 400 they think that are really moving in this direction. So I think the Betsy Lehman Center can be a catalyst for you all to get that implemented and ready. As I said, so these are the national trends. It really is becoming sort of the way that people are thinking about handling adverse events now. When we started doing this 10 years ago, it was not. When I first took this job, people said, that's crazy, right? That's crazy. You're going to tell people that you did something wrong. And now I really truly feel that this has become something that most places are interested in doing, but it is a lot of effort to actually put the program in place. And so we want to be able to help with that. There is an open source Candor toolkit that was developed by ARC, so that's out there, and a lot of those tools are very similar to what we offer. There's a PACT collaborative, which is sort of like a national Betsy Lehman Center type of group that is trying to get sort of what we have here in Massachusetts up and running nationally. And so we are also a part of that and help support that as needed. But really, in the past 15 years, this has gone from something that was really not very well known at all to something that is now really nationally renowned. And it's also been part of the recommendations submitted to the President of the United States for help nationally to try to get some supportive funding for making this a requirement for facilities. I don't know where that'll go, but it certainly is getting some press, right, like around the whole country. And so I think we're on the forefront of that here in Massachusetts. So if you are here in Massachusetts, it's free to get implementation help through Betsy Lehman Center. So we hope that you will join us for the next year. Any questions about the basics of care? Someone online has a question.
We have a couple of online. Yeah, a couple of online questions.
Sure.
Roughly how many cases were included in that pilot study that you referenced?
Sure. So there were almost 1,000 cases. I think it was like 992. Yes, there we go. That is 992.
Okay, great. Thanks. Also a question on what is the process or mechanism used to reach the conclusion around whether or not the standard of care was met?
That is a really good question. So for those of you that aren't inside of sort of the quality and safety departments in healthcare facilities, there are a number of different ways that facilities look at, did we meet the standards internally? So there are some processes that they use called root cause analysis. So there will be folks that interview everyone that was involved in the event, look at some of the policies and procedures that are in place in those departments for whatever the event was, and sort of try to come to a consensus about what was the root cause of that error, and then how are they going to fix it, what are some of the corrective actions. Then they also have other reviews like departmental reviews, where the department itself will look at it. That could be an M&M or some other structure, mortality and morbidity rounds, or another structure that they are looking at it as a department if it happens in a single department. And then a lot of places also have integrated interdepartmental review meetings where they do the same thing. They each have a quality director or other folks that will review those records, look at what happened, interview people, and try to find out, did this meet that standard? Is this what we would, if some other provider came in and did this, would this be what we expected, and those kinds of things. There are other kinds of reviews that they can do as well. Each case they sort of assess, what is the severity of this? Who do we, how much effort do we need to put into figuring this out, or is it relatively obvious? There's a number of different strategies they have, but usually that's a system that is already part of their structure, and care being overlaid on that kind of just makes it a little more solidified, so that they, at the end of that process, they have to be very explicit about saying, did we meet the standard of care? And that's something that not every site does right now. They do a review and they try to figure out what happened and sort of find corrective actions, but being very explicit about that helps us to decide then what is the resolution going to look like.
I know the answer is yes, but maybe you want to just,
Okay.
do you offer resources for patients on how to have a successful conversation?
Yes, so we do have a lot of resources on our website, which I'll show you in a minute. I was going to show that, but I'll have Michelle bring that up. But we do have a new website with a new resource library. I don't know, Michelle, if you can navigate to that or not. If you can't, that's okay. We can show them after, but
we'll put a link in the chat.
Okay, so yeah, we do have resources for patients. There is a page on our new website that has FAQs for patients on how to navigate this and what do these different things mean. There's also a glossary of terms because sometimes, as I just did, we use terms like M&M, and if you're not in the industry, why would you know that? So, and we also have the Betsy Lehman Center offers support to patients. There you go. Linda, give me a thumbs up. Offers support to patients through their peer support network, which is an invaluable resource, which I would say all of you should just go back to your facilities right now and put this on your desks. And every time a patient needs help, if they've had an adverse event, just give them this number, because they are able to match them with someone else who's had an adverse event that's, you know, had a similar experience, and that can just talk them through what their experience was like, validate what they're feeling and all of that. So I don't know, Linda, if I characterized that right, but you're welcome.
You're perfect.
Okay, great.
Spokesperson for our support program, you can.
Good. Well, yeah, so that's right. It's online. You can find all the details there, but they are ready and waiting to help your patients. So
there's actually quite a few questions, so I don't know. In the interest,
we have, let me see. Yeah, we have 5 more minutes. So that's fine.
Okay. We have someone who's curious about the 13 sites that are currently working on the care model here in Massachusetts. Should we just type that into the chat? Do you want to?
Yeah, so actually there is a link which we can send in the chat. There is a page on the website that lists all of the sites that are currently fully implemented. And then we don't have a list of those that are working on it, but you know, I can certainly let them know.
Right. Okay. And then another question on whether or not you're aware of any interest from CMS in piloting a program like this.
Yeah, so I don't know that they've expressed a lot of interest, but I do know that nationally folks are trying to advocate to them to say, is there a way that we can create some standards around this? I don't know that anything has happened yet, but it's definitely something that people have set their sights on. So that's all I know so far.
Yeah, and also a question on healthcare facilities that aren't hospitals.
Yeah, sure. So we do work with Atrius Health. That's our big multi-specialty group, and Baystate medical practices. So those are our sort of big outpatient practices that are not hospital facilities. For some very small offices, we haven't had a lot of traction with them. We are trying to sort of get to them through systemic networks. And that is something that we are, I wouldn't say have a lot of traction with yet, but that's something that we're working on. Certainly any of those sites can reach out to us and do this. We can modify the way that we implement this to a way that will work for them. So I'm certainly open to any of them. I think they just probably have a few number of adverse events, and so they probably don't have a structure in which they feel like they're activating something like this all the time, but certainly we do, and we'll do that for them.
I bet this one's complicated to answer. What's the average time from the event to the initial meeting with patients and families?
Yeah, that's a little bit challenging to answer. So I would say what we try to do is have the initial meeting around what happened as soon as possible, right? So within 24 hours, but there are many cases in which that wouldn't apply, right? Like a delay in diagnosis, or a patient may know about something that we didn't know about. So we try to do that as soon as possible. But in terms of the resolution meeting, where we have done the investigation, we know, sort of the outcome around standard of care and causation, that I would say the ideal time would be 30 days, but it is very difficult to get that to happen. And I would say that often happens within 2 months. That would probably be more of an average. I think a lot of folks have a lot of backed up meetings, and it just takes a long time to get all of the opinions that you need to make sure that you have the information for the patient that they need and to get their questions answered. And so I would say we always try to do it as soon as possible, but I would say 2 months is probably the average for the sites that we've seen.
Okay, and if you have time for one more,
yeah.
I recently had an attorney communicate to me some concern about patients accepting what's offered without assurance that the patient is receiving what they should receive. So what assurances are there that the offering of resolution to the patient is appropriate?
Yeah, that's a really good question. So I don't know if all of you in the room are able to hear that because of my, but what she said was someone had a concern from an attorney that patients may not be getting an offer of everything they deserve, and how can they make sure they do that? So the answer that I would say to that is that when you have a patient that is going to be in a situation where they're potentially going to receive compensation, it's really important part of our process to make sure they know that they should have an attorney or that that attorney is recommended. And that's precisely to mitigate that, right? Because the point of the program is not to undercut a payment to the patient. The point is to save, of course, prevent errors from happening again, but in terms of being fiscally responsible, the amount of money you save is on litigation costs and other costs surrounding experts and things like that. It's not for the patient's compensation. That should be the same. And in order to help them feel that they are getting appropriate representation, we want to make sure that they have someone that's an expert in that. And the Betsy Lehman Center has now a list of attorneys that have consented to abide by the best practices, have watched a training. So those attorneys are usually great choices for patients, but those are by no means the attorneys that they have to use. They can use anyone they want, or they can decide not to use one. But it is important for us at that level, when it gets to the threshold of we didn't meet the standard of care, we think this caused you harm, that they are informed that an attorney would be a good choice. So, I mean, that would be my recommendation, is to get an attorney in and still work in this process. Yes, Peter.
Quick question. You talked about other healthcare facilities. What about extending this to like post-acute care facilities and nursing homes where adverse events occur there as well? They're often left out of these systems.
Yeah, so I think we certainly can do some more work in this Commonwealth to be able to advocate to them and say this is available to you too. We haven't had that many respond to that yet, but I certainly think that there is a need. Nationally, we have done that with 1 or 2 sites, and so I think there's a precedent and ability to sort of pivot from what we're doing to using those practices at post-acute care and nursing facilities as well. So again, any kind of healthcare facility in the state is able to do this, and we can certainly help you to implement it in your setting. Okay, great. So now we're going to move on to the simulations. This first simulation, we're going to put a case description up here. This is one that is a real case, but the actors, everyone in here is an actor. So sometimes we do have, the actual people that are involved, but in this case, they're not. I do want to mention before you watch this that because everyone's an actor, they do have papers. They don't look at them all the time, and they may or may not be notes or medical records, but you will notice that sometimes they look at them. That's just because they have a little bit of scripts to reference to. But this is the case that we're going to present to you today. So we're going to watch 4 different scenes around this. The first scene will be finding out about the event and sort of reporting it. The second scene will be the initial disclosure. The third scene will be patient safety's additional disclosure. We get a lot of questions about this. What happens if the disclosure has already occurred before I and patient safety know about this? And so we're going to show a sample of how you can handle that situation, which is, it's totally fine if that happens, and it will happen a lot. So we wanted to show that. And then the fourth scene will be the resolution conversation. So I'm just going to give you a minute to read this, and then we'll get started.
Hello?
Hi, Carolyn. This is Sarah from the ED. I have a patient here I'm worried about. I think something might have been missed. He just presented to the ED with trouble breathing and has had significant weight loss. When I was reviewing his file, we noticed that a chest x-ray back 2 years ago when he was here for a stroke showed a mass. I asked him whether he had had any follow-up care regarding this, and his daughter got upset and said they never knew anything about it. What should we do?
I'm sorry. All right, let me have a member of my team take a look at the patient's chart right now. In the meantime, tell the patient and his daughter that we're working to figure out what happened, and we'll let him know as soon as we have more information. In the meantime, just assure them that we're taking care of his needs right now and that he's in good hands. He might be worried about that.
Okay, I'll do that. I'm going to have him go in for a CT scan now, so I'll let you know what we find. Please call me as soon as you can. It'll be hard to keep facing them without more information on this.
I will. Thank you, Sarah.
Thank you. Hi, Mr. Sloan. Carrie, I have some more information about the chest x-ray I had mentioned earlier, and I wanted to share that with you. Is now an okay time? Okay, well, we reviewed your medical records, and while you were here last February for your stroke, you had mentioned a persistent cough. The ED doctor at the time had ordered an x-ray of your chest to help determine if that cough was concerning. At the time, treating your stroke was extremely important, and that was the priority to address. In the meantime, your chest x-ray came back, and the radiologist found a concerning area. This was flagged, and a note said that it needed to be followed up on to determine if this area was what we would call malignancy or a cancer. We are so sorry, but we discovered that this note did not end up in the right place in your chart for your doctor to see, and we now realize that this was never followed up on or reported to your clinicians, both of which should have happened. This is our fault. It is our responsibility to follow up on finding. I'm so sorry.
I don't understand how this can happen.
Wait, this whole year since I was here last, this cancer's been growing. We could have taken care of it. Now it's just gotten worse.
Yes, unfortunately, that's the case.
I can't believe you don't have a system to follow up. We know his stroke was important at the time, but can't you do both things at once?
Yeah, usually it would be put in the chart, and the attending doctor would see it, but somehow the system that didn't work this time. And honestly, I don't know how much earlier treatment would have helped the cancer growth to slow, but it is likely it would have helped somewhat. I don't know how much of it, or if it would have lessened the pain you've been feeling, or if knowing more about it in February would have changed your prognosis or treatment options. But this is something we can look into and get answers by discussing with doctors here who are experienced in understanding the evolution of cancers such as yours.
Oh my God, I can't believe you took such good care of him, but then failed in this way that now my father has cancer.
I know, it's unacceptable. We should have done better. We know you trusted us with your care, Mr. Sloan and Carrie, and we're so sorry this has happened. But we want to be transparent with you. You deserve to know that we made the error, and you deserve answers, not only because they impact you, because we don't want this to ever happen to another patient.
No other family should get news like this when they come in.
No, absolutely not. And on that note, we do have a Department of Patient Safety, and they'll be digging more into this and making discoveries about what the impact is to you, how it happened, and how we can prevent
That's great that you're going to do that investigation, but what are we going to do for my father now?
Absolutely.
How are you going to?
Yep, that's a plan that we can discuss. We can discuss amongst ourselves. We can be in touch with your doctors as well.
I know this is a lot to take in.
I know, and you have every right to feel this way. And I'm so sorry. I know that this is probably overwhelming. Is there any way, would it be helpful if I brought in a counselor or a chaplain to spend time with you in this time?
Don't you want to?
Yes.
Okay,
Yeah.
I'll make sure I do that. On behalf of myself and everyone here, I just want to say that this was a horrible mistake, and we will take responsibility for it and dig into it, because, well, that might not give you any comfort, Mr. Sloan. We really want to find out what happened. I'm so sorry. I'm so sorry.
We appreciate you being transparent, but we're still probably going to deal with the anger around this.
Absolutely. However you're feeling is the right way to feel. Something like this can be very complicated. But we are here for you, to support you ongoing, and to hopefully rebuild that trust. So if there's anything you need, Mr. Sloan, I'm so sorry. But myself, my team, we're all here. Feel free to reach out at any time.
Hi, Mr. Sloan. Carrie, I'm Carolyn Fordham from the Department of Patient Safety. It's nice to meet you. This is my colleague, Lynn.
I am Lynn.
Nice to meet you. Do you have a few minutes to talk right now?
Yeah.
Okay, great.
Get nothing but time, right, Deb?
How are you feeling?
I'm a little tired. I'm really not myself.
Of course. I hope that we can help you to feel more yourself and get you home soon. I'm here to talk a little bit more about the chest x-ray that the ED doctor came and talked to you about, that we missed the finding of cancer on it when you were here originally for your stroke. I just want to say, first of all, that I'm so sorry that we missed this. We take this really seriously. It is not acceptable, and it is our responsibility to fix this. Lynn here and I work together with a big team of people in the hospital to identify how this kind of thing could have happened and how to prevent it in the future. But our other job that's very important is to figure out how it's impacted you personally, what this miss has caused in terms of your cancer prognosis, and also to just figure out how we can actually help you right now with what you need. Is there anything that you are thinking right now or questions that you have?
No, I just can't believe this happened when you took such good care of him before, and now he's got to deal with cancer. And if it was picked up, the prognosis would be better. You know, he's suffering. He's he can't take care of my mother anymore. My brother and I have been trying to help out, but it's stressful, and I think this affects his health and his, looking at treatment.
Mm-hmm. It's exactly right.
And I hope you can make this good for him, because this has not been fun for my family and I, and my father's suffering.
I completely understand. I'm so sorry, and I want to be able to do all of those things for you, and that's what we are going to do. So right now, we can't tell you much about how much the delay in finding that chest x-ray result has actually impacted your cancer, but that's one of the first jobs that we have, is to make sure that we get all of your oncology experts looking at this to get you the best plan that you can and figure out how much that miss has impacted you. And then because of that, also part of my job is to figure out how can we help you support your wife. How can we help you get the resources you need so that you can get the care you need right away? Lynn is also part of this team, so she's going to help me find those answers and any other questions that you have. So Lynn will be your main contact. As you leave the hospital, you may have questions or concerns or worries, and we want you to be able to be connected to us at all times. So Lynn is going to be that point of contact. And of course, I'm available as well too. Yes.
Here's my card. Please feel free to reach out at any time. I will be in touch later with any information that comes out of the review. In the meantime, is there any way we can help you?
I'm not my wife's only caretaker. I can take care of her. I just can't.
I completely understand. Give me some time to talk to my team members, and we'll get back to you on how we can help. In the meantime, is there someone that can take care of her right now?
You know, there's my son, but he can't take this on right now.
Well, we can certainly work together to find someone to help take care of your wife, whether that's visiting nurse or some other thing that will help you to be able to feel like she's getting the care she needs.
Is there anything else you think you need right now, Deb?
No. Thank you.
Okay. Well, you have our contact information, and again, we are so sorry.
So if we have any questions, we call Lynn.
Yes.
You're going to be out. Okay. When do you think you'll be done with this investigation? How long does that take?
It's a really good question. It usually takes us around 30 days, but we try to do it as soon as possible. So we certainly will find out more about your particular diagnosis and how we can help you much faster than that. But if you're talking about our plans to figure out what are the causes to these problems and how are we going to prevent them in our own system, sometimes that does take a while, because we have a lot of systems that interact, and we want to make sure we know exactly how it happened and how to prevent them. So it does take a little bit. Okay. Anything else we can help you with right now? Okay. Thank you so much for taking the time to talk to us.
Thank you.
Good afternoon, Carrie. It's good to see you. Thanks for coming in today. And I want to express my condolences on the loss of your father. He was such a wonderful man.
Thank you. He was.
Yes, he was. I hope the conversation this afternoon will be helpful to you. I wanted to have everyone introduce themselves. Doctors, would you like to introduce yourselves?
Hi, I'm Dr. Kumar. You may remember me from your father's first day during his stroke. I'm one of the neurologists who had the privilege of caring for your father. He was one of my most memorable patients. We found that we shared a love of attending the symphony. Yes. And we discussed a few of the latest programs at the BSO.
Yeah, he never missed a show if he could help it.
Hello, I'm Dr. Lauritsen, and I'm the Vice Chair of Radiology. We haven't met before, but it's part of my job to help determine both what went wrong in following up on your father's x-ray and also how to improve the way we do our work so that this doesn't happen again. And while I never met your father personally, I know my team members had great respect for him. And I want you to know that I take my responsibility to correct these issues with radiology follow-up extremely seriously.
Thank you.
And you know Lynn?
Hi, Lynn. Hi, I'm Lynn. We met before. Nice to see you again.
And this is Mr. Hansen, an attorney for the hospital, and of course your attorney, Ms. Smith. So thank you for being here today. I'd like to start off the meeting today just really by reaffirming the most important thing, which is that we are so sorry that this misoccurred on our part and for the heartbreak it's caused you and your family. I want to let you know that we were able to understand things a little better after doing our research into this event, but I first want to check in with you to see if there's anything in particular we can answer for you right away.
Not at this time.
Okay, great. So I think it would be probably helpful for you to understand a little bit more about the clinical situation. So Dr. Kumar is going to explain that.
Sure. When your father originally came into the emergency room 2 years ago, he was very sick. As you know, he had a stroke, and I had to address that very urgently, or he could have died right then. We were very focused on his care around this, and so we were not aware that a chest x-ray had been ordered due to his complaints in the emergency room about his cough. It was not something I myself ordered, and so in order to communicate studies or x-rays ordered by other physicians, we have an electronic medical record that alerts us to these other studies. We realized in looking at your father's care that we need to do a better job communicating when studies are ordered in the emergency room that are outside the scope of the urgent problem. I didn't realize your father had other complaints not associated with his stroke, and as a team, we need to do better communicating in other ways aside from the medical record. When the radiologist, the doctor who reads the x-rays, reviewed your father's chest x-ray, he noticed there was an area of the lung that was concerning to him, and so he put a flag on the x-ray to alert anyone reading your father's chart that there was a need to follow up with this. While the flag was there, the next issue we found in review was the x-ray was not mentioned in the discharge summary, which is written to give doctors caring for the patient at a later time a way to see at a glance what happened to the patient in the hospital and what still needs to be done. This shouldn't have happened. The x-ray results should have been mentioned during the discharge summary so that other doctors and you and your father would know this was important to follow up on.
You know, I don't understand how you could miss that. And you know, I was looking at his online record and I didn't see anything. I don't understand how you miss a flag if a flag's for something important. If that's the way to alert people, how are you going to make sure nobody misses another flag?
Well, that's a great question, and we've been asking ourselves those same things. So we did have some things in place to try to prevent this, but we discovered that they clearly weren't thorough enough. And we know that since it's a human being's job to write a discharge summary, sometimes things do get missed. And unfortunately, this does happen from time to time as doctors have many patients and there are lots of discharge summaries to write. So as the vice chair of radiology, it's my job to help create systems that prevent misses like this. And because we know that people aren't perfect and they do make mistakes. Now, we did have a computer system in place called Radar, but we noticed during this review that our Radar system didn't have a wide enough range of words to look for in order to automatically flag them, as Dr. Kumar mentioned. So we've now added more words like mass to the system to be able to make it better at identifying needs that may be missed by human beings.
I just still don't understand how this could be missed. It seems incomprehensible that something like a mass could be.
I understand.
I as my father's daughter, I just assumed you people talk to each other. I didn't know.
We do talk to each other, but we also do have backup systems in place. Now, as a radiologist, I see many patients' x-rays, but I never meet them directly. And the patients' doctors that see them face-to-face and manage their overall care take my findings from the x-rays, and then those doctors decide how to proceed. But it's part of all of our jobs to make sure that the transfer of the responsibility around the follow-up on x-rays is accepted and that there's a specific plan in place. Now, this was also one of the issues that we uncovered from your father's situation. So now what we've done is that we've developed a new system which requires the original doctor whose patient had a flag result to be responsible for the transfer of that follow-up to another provider in a very specific way. So the original doctor must create a follow-up plan which requires an appointment to be made with a specialist who will then be responsible for further exploring that flag result. Now that plan will be entered into the computer system so that the follow-up's clear to everyone, both the specialist and the primary care provider for the patient. That way, the primary care provider and the specialist will be alerted if there's any missed follow-up appointments and they can address them. Now, I understand that these improvements didn't help your father, but I want to make sure that this never happens again. And I do hope that it helps you understand more about what happened and how seriously that we are taking this.
Well, that's good to know, but as you know, it doesn't help him. But I'm glad no other family has to go through this again.
And we want you to know that we are trying to learn from this experience, and we are trying to fix these failures.
Yeah.
Like I said, it doesn't help us now. We're glad you're being honest. But we lost our dad. You know, we're missing a big part of our family now. You know, my kids don't get to know their grandfather. My brother's kids don't get to know their grandfather. My mother lost her best friend and partner. I mean, it's had our family has a hole in it, and we appreciate this, but it's not going to make him come back. And 2 years of lost time, you know, I wonder if we knew about it earlier, if we could have had some great quality time, because the last 2 months have been, the last couple of months of his life was painful to watch the man become a shell of himself. We trusted you, and you failed, and now my father's gone. And we, you know, we might never know if he'd still be here if we caught this earlier.
And I'm so sorry. I know we can't bring your father back, but we do want to do right by you in the best we can under these circumstances. It is our responsibility to do that. As I mentioned to you before in one of our previous conversations, we use communication, apology, and resolution. And the reason we do that is because we feel like that is the right thing, that we would all want that if we were patients and something were to go wrong. We want to be honest about our mistakes, prevent them from happening again, and support you and your family. And one of the ways that we do that is by having our insurer take a look at what happened here in this clinical situation and make an assessment of possible compensation for you and your father and all that he suffered and your family has suffered. What do you think about that?
You know, it feels like I'm making money off of my father's death, and that's not what it is. I mean, it would be nice to have money to help take care of my mother's needs, since my brother and I are not able to that would be helpful, and I know that would mean a lot to my father to know my mother was taken care of.
Of course, of course. And I don't want you to think of it at all as profiting from something terrible that happened to your father. It's things that you need and deserve. And this shouldn't have happened, and it's our responsibility to make that as right as we can.
Thank you. What do you think?
Yeah, I think you should proceed. I think they've shown today that they're making, a good effort of good faith, so I think it's okay to do the same.
Great. Okay, so I'll put you in touch with the claims representative at CRICO. Carrie, is there anything else that you want to know about or you want us to know today?
Can you use my father's case to as a learning tool for others so that, as you're fixing the systems, they can know that these are the consequences when things get missed?
Yes, absolutely. And actually his story has already been used in a lot of the different departments that we went to talk about what has happened and who he was and why this really mattered a lot. We also have a lot of opportunities in the future to do this. So when we have new residents coming into our facility, new physicians that are joining us, we want to use examples like this to show them that these are people that they are caring for, and that we want to all be very vigilant about how we are caring for our patients. So we will continue to do that. But I would love to have you work with us if you think of any other ways that you might want to have his story shared that would be effective, because we think that would be very valuable as well.
I think if my father were here, he would be happy to know that it was being used to save others from going through the same thing.
Good. Okay, great. Well, we can definitely do more of that and continue to do that. So
thank you. We appreciate the kindness and the empathy that you've all shown me and my family. We appreciate it. And I didn't realize until I had done some reading that this communication and apology thing you're talking about wasn't always done. Mm-hmm. So knowing that now, I really appreciate the fact that you are being open and honest with us.
Well, it's the least we can do. And again, we're so sorry.
And I would love to share with you, if it's at all helpful, or support for patients and families. It's called the Patient and Family Peer Support Network. It's out of the Betsy Lehman Center, so it's a state agency, so it means the support is completely free. It's meant to support patients or families who are going through something like what you're going through. So the way it works is that they will match you with a patient or family member who knows what it feels like to experience what you're going through. I have a brochure here that can tell you more information about how to get connected.
I would love that. Thank you very much. Thank you. Appreciate it.
Well, if there's nothing else, we just really want you to know how deeply sorry we are, and that this has changed the way that we work here at the hospital. If you need anything else or you think of anything, please, again, feel free to have Jane reach out to us, and we are happy to help.
Okay. Thank you.
Thanks.
Okay, so I would love to hear, as you all are have had lots of experience with resolution conversations in different roles. I thought it would be valuable to hear from you about what you just saw, some recommendations, and then of course we'll take some questions and impressions from the audience as well. So I'd love to hear from each of you your first impressions of what you saw. Did you learn or see anything new that you would want to use, or anything that you might do differently? Peter, do you want to go first?
Sure, put me on the spot first. The first thing I would say is I wish every case were straightforward like this. Man, this one was fairly black and white, but I think we have so many gray areas that this is really hard to do. And so that's the first thing I would say is it looks easy when it's up there, but it's never this easy. It takes a lot of planning, a lot of practice, and a lot of pre-meetings to get to that. So that's the first thing I would say is it's okay if it doesn't go as perfectly as that. A couple of things that I noticed and learned. The first is you had in this scenario, I think because it's probably a larger hospital, you had an attorney for the hospital and an attorney for the patient at the resolution meeting. And that is not something that many hospitals are going to be able to do, especially smaller hospitals. When we've done this at Milford, we have communicated with our claims representative from the insurance companies, but we had not had an attorney or even the claims rep at the resolution meetings. And oftentimes what we're doing at that meeting is relaying the apology, the facts, and then the decision is made that we want to refer this to the insurer for a care insurer case, and so we'll then have to bring them in afterwards. I think that's a step that makes us even harder than when you have those individuals present at the meeting, first of all. And I think because of that, you were also able to have an initial conversation here about offering some compensation, which is really hard for us to do when we aren't part of a captive or have the insurer or the attorney at the table for that. And so I think you had to be very clear in this case that there was an absolute reason for compensation. In most cases, it's just not that simple. And so I think that makes it just more complex than it otherwise would be. But I think I've learned through this case that, there are some times where we probably can work with the insurer to agree that there might be a role for compensation before we come to the table with the patient and the family. The other just sort of reflection I have on this is these are the hardest situations to do when the patient has died. And then you're coming to the table with a family who can't as accurately represent the interests of the patient. And there's a lot more emotion and anger and feelings at the table for this. So just want to reflect that that is another sort of challenging one. And then just finally, before I turn it over, I think the issue of the attorney at the table, we have had recently one circumstance where, and we usually address ahead of time who's going to be in the room when we sit down with the patient and the family. We had one circumstance recently when we had an attorney come into the room with the patient and family unexpected. And thankfully, we worked with you ahead of time to know how to respond to that. Basically by saying, it's okay for you to be here, but remember this is a discussion of what happened, not a deposition. And if it turns into a deposition, we're going to have to end the meeting. And again, I'm sort of appreciative of the guidance that you've given us, Melinda, but I think it's okay if you end up with an attorney in the room as long as you hold to those stipulations.
Yeah, I think that's a really important point, Peter, just to distinguish that this case, it was very clear, and that patient had already, or family member, had already brought an attorney. So that was already something that we had to incorporate into the process. It doesn't always go that way. And often those meetings are a situation in which it's the clinical team talking with the patient and family, and then it's transitioned over to the insurer. So all cases are different, but that's a good point to make sure that this is that. Pat, do you have some comment?
I do. I thought the resolution conversation, the whole thing was like case perfect in a way. And, there's all the things that you don't see are the things that went on behind the camera or behind the scene that got to those meetings. My first reflection was the fact that the physician who noticed the disparity in the emergency department actually called the Department of Healthcare Quality. So what does that tell me about the organization? It tells me that there was some deeply appreciated and understood standard work that clinicians knew that you should get help when you're going to have these conversations. And what you probably didn't see in that scenario is that maybe for like a year or two before, every physician had to know that this was the way the hospital was approaching adverse events, and every clinician had to understand that. Partly because we want to make sure that people get help for those conversations. So imagine if that first conversation was an emergency room physician and a patient where she had noticed that there was a discrepancy where something was said, for example, this always happens with radiologists. I tell them all the time that they should be more prescriptive about their notes or something like that, which does happen. I think the other thing that is a frequently asked question that I get, and Melinda has gotten a lot also, is whether you train everyone about how to do a disclosure conversation, or you train everyone that this is a high-risk conversation. This is the way we approach it. So you need to get help before you have that conversation, because the need to get just-in-time coaching is really important. And so I feel like this points out the fact that there was a lot that happened before. There were also, like, if we went into like criticisms, moments where like I tensed about some of the things that were said, because what we teach is not to speculate. And there was a little bit of speculation in that initial conversation. And it's really hard for clinicians to steel themselves against speculation because they're used to giving the answers to patients, right? So, and it's also a fine line, Peter, you know, as an emergency room physician, between speculation and withholding. So it's such a delicate dance, which is why you need help. And then maybe I'll just stop there with that because I'm sure there'll be additional things that we'll talk about. But those were my initial reflections about entire set of communications. So I'll turn it over to you.
So something that stood out for me was that they brought in the vice chair of radiology, and he introduced himself and he explained what his role was. His role was to review the care and also to find the error and then to explain that to the family. When you walk into a care conversation in a room, you see that there's a lot of hospital personnel there, and it can be really confusing and inundating for patients and families. So I thought they did a really nice job introducing who was at the table, who their roles, what their roles were, and bringing in the people who had the answers. So if this were a different type of case, our practice is to make sure that we have all the providers involved in the medical care. We would anticipate the patient's questions and bring in those specialties as necessary so that we're not going to frustrate the conversation by saying, gee, we'll have to get back to you on that. But again, we had all the right people at this table. And in this particular case, it was a very good example in having the vice chair of radiology to be responsive to the family. I thought that was very important, very important. So I love it.
Just wanted to add one thing related to Pat, your important comment about speculation, which is really hard with knowing what the exact facts are. But I think what I try to train all of our clinicians to do during that very first meeting is just be really simple. And the simple 3 steps that I say are make a statement of regret or empathy. So not an apology because it's not ready for that yet. But a statement of, I'm so sorry this happened to you. I can't imagine how you feel. Don't ever let people say I can imagine how you feel because they can't. So I say, I'm so sorry this happened. I can't imagine how you feel. Here are the facts as we know them now. We're going to continue to care for you. We're going to continue to make sure you're taken care of. We're going to review this. There's a lot we don't know right now, but then we're going to get back to you. And then obviously we have to provide them with follow-up and a time frame for that. But I think those 3 steps are easier for people to remember without having to be trained in all this thing. But they can remember just that, and then we can follow it up with more of a process later on. But one other thing I can't remember I wanted to say, but I'll come back to it.
Well, I think you've all hit on this point around preparation for these different pieces, and some of that is long-term preparation, and some of it is sort of right before you're going to have this conversation. Do you have any recommendations around the resolution conversation preparation and things that you would do for the providers that are involved, for sort of everyone in the system that needs to know that this is happening, anything like that?
Well, I think you have, I would say that at least I would be interested in your feedback on this one, but if you have the luxury of time, which you did to set up that final resolution meeting, it's probably a good idea for people to get in the room and do a bit of role playing. That was an incredibly calm meeting. That was a gracious family. That was very grateful for the care they received. But you need to be, like, I think health clinicians be prepared for more affect in the room. And to just be ready for it in case it happens, and to have a contingency plan, if need be, for what you would do in that case scenario, who's going to step in, et cetera. Things, just be careful about what not to say. Just doing some role playing when you have the opportunity is really helpful.
I would agree with that. I would say that there is a lot of preparation that goes into the disclosure meeting and also the final resolution meeting when you're discussing the findings of the investigation. Very similar, what to say, what not to say. We often recommend, maybe avoiding clinical terms, technical terms. We really want this to be a conversation. We always want the patient and family. This is sort of my rule. Number 1 rule is after we do introductions, have the patient and family tell you how they feel, what their perceptions are, what their questions are. That gets the conversation started. That way we have something to respond to, and we're not sort of coming into this conversation based on our assumptions, because that usually does not go well. We can never assume how the patient and family are feeling, really. So a lot of preparation. Don't be afraid to have a couple prep sessions. Make sure that your team is comfortable to go forward. I also always like to make sure that we don't get ahead of ourselves in our conversations when we're talking about an initial disclosure. We let people know what we know at that time. We certainly want patients to be making informed decisions about their care after we know that there's been an unexpected outcome. So again, just a lot of that preparation and a lot of coaching, make sure that your team members know that you're accessible too.
And I'll just bring up one other part of this. We have a question, I think, in the back, which is, of course, much of this is about just and timely resolution for patients and families. But I also want to just keep in mind that in order for this to work, you have to keep trust with the clinicians. Most of the time, it's going to be physicians because they're the decision makers. So I think as a physician advocate at the table, you have to maintain the trust of your physicians. But how do you do that? I'll take a quote from Rick Boothman, who borrowed it from Don Berwick, who said, "Nothing about me without me," which means you don't take any steps throughout this entire process without communicating with the clinicians involved, making sure they know what's happening, making sure they're okay with what's happening, and making sure you know whether they want to or can be at the table during these conversations. And if you don't do that, and if you leave them out of this process, it's going to fall apart really quickly.
I would just add to that here that we also want to make sure that we're rolling out peer support for our providers. It's a two-part. We can't address the patient and family and their needs without addressing our providers' needs as well. So as much as we don't necessarily put that on the forefront of patient and family, those are part of our conversations with our clinicians to make sure that they know that they have our full support and resources for them as well.
And I will say, in your packet, you'll see today there's a resolution conversation checklist, and that was a resource developed by us at the Betsy Lehman Center. It incorporates pretty much what we talked about here today and some other pieces, but that's available for download as well. But just so that you have something and people feel like it's really helpful to see, well, am I making sure I'm doing all of these things before I have this difficult conversation? I think we'll open it up to questions now.
I just wanted to say, Peter, what you said was so simple, but yet brilliant, because saying to the patient that you're sorry that this happened, and that never saying, I know how you feel. However, in fact, that was done in time. And the other thing is, I really do think, and you know, I've been on both sides, I think the clinician really needs support because it's a hard conversation. And I was only PG because Melinda wrote this. My husband.
Linda, the one thing I was going to say about what you just said about today, I'm so sorry this happened. What a social worker who I would be your that I worked with when I was at the medical center once said to me after I said that to somebody that you should never end with, "I'm so sorry that this happened." You should always end with, "I'm so sorry that this happened to you." Yeah. Partly because you are so sorry it happened for yourself, maybe, right? And it's just to be that it's really okay to say that and to really, so I like to just keep it in my mind to always make sure I'm ending with "to you." Yeah.
And I just wanted to say one thing too, which is that I agree with you that there can be lots of different strong emotions, but I didn't just make this up. This is actually how this family did respond. So sometimes you do get families that are very gracious and respond in this way because they're not expecting you to be so forthcoming as well. So there is a wide range, but I didn't just make it seem great because I wanted to do it. So, all right, any questions in the room first? If you could use the mic, that'd be great, just so everybody can hear online.
Hi, everyone. Okay. My name is Jennifer Powell. I'm a family medicine physician in Malden, part of Custom Medicine. I had a question about, sometimes I know patients can report to the Board of Medicine about a concern with the provider. So how is that handled if the board is also investigating as well as the hospital team?
We all have perception.
So sometimes we do get notice, and it's a pathway for patients to take. And maybe they didn't let us know that they had a patient complaint. They wanted to come in and talk to us about their care. Certainly, we do need to manage the form inquiry and that investigation. And again, we want to offer support to the provider and make sure that they're aware of everything that is going on while we're also investigating as well. So I think in the bigger paradigm here is when can we merge the two? When can we start having that conversation with the patients and families? So very case by case specific, I would say, you know, In those cases, we would certainly want to reach out to a primary care physician if an injury occurred in the hospital, for example. You know, reach out to another provider. How's the patient doing, and checking in. And you know, you just want to use what resources you have to be able to reach out to that patient and make sure that they're doing okay and be responsive, because really it's all about being proactive.
I would just say, I don't see that as much of an issue. As a more common occurrence we have is when we have a grievance that comes in and says, you know, we have to respond in writing to the grievance within 30 days. So it becomes really hard to make sure that we're responding to the grievance and then doing the entire review of the case and setting up a meeting with the patient and their family to talk about something that we're responding in writing with simultaneously. So that becomes a little bit more challenging than I think whether you have to, because you're in for a board complaint, you're going to have them have legal representation to have a response to the board. I think that's somewhat separate from the process of just understanding what happened and then deciding whether you're going to sit down with the patient and family to review that. It could be something you think is a totally spurious report to the board or not, but
On that same vein, though, and I think I've seen it more often, is that it's a requirement to report to Department of Public Health, right? And that these patients or the families will get a report. And I have, in the couple of times in the past year that I've had to have these conversations, say, well, this is something that is going to the state level. We're investigating here, but we also have to prove to them. And that has, in my experience with these couple of families, been a relief that it's not just going to end there. And then it also buys us the 30 days time to get the investigation done. And I was just wondering if you think that that is good practice or riskier than it.
I think that was great practice. And this comes up more often than you would think, probably. And I would just say that what we also want to do is, because we know that patients and families are going to receive a copy of that 30-day report, we want to be consistent. And so, you know, and it holds us to the transparency. This is what happened, and we're reporting this to the state. And, you know, whatever is shared in that report, and we want to invite families to come in and talk about that. So again, 2 different tracks where they're going to receive a copy of that report, and then we may have, you know, another letter coming from our patient relations department asking, you know, if you want to come in and talk about that, that's okay, because we all know that some of those reports are written for that purpose, and they're not exactly patient friendly. It doesn't necessarily explain, you know, what happened and you know, that we do care that this happened and so forth. So absolutely, very good way to respond. Sure.
And I will say, if those of you who don't know about this, on the resource library, we do have some templates for those DPH letters that sort of integrate some care language, so that when it's coming from you as a site that uses care, it reflects that you are looking at this in a transparent way. So there is some integrated language. Should we take one from online? An online question.
Yes. Can you hear me? Yes. All right. I'll combine a few questions here. So what happens when the patient or family is not able to be on site? Let's say this happens, folks have left the hospital, they're not from the area. The second one that can complicate things is the very angry family, which I think, Pat, you alluded to. And the third one is, what about when there are multiple specialties involved?
Okay, let me just repeat that in case they couldn't hear on the mic. So it's when a patient is not on site, like they were here, they've gone home or they're far away, that if there's a patient that's very angry or upset, how do you handle that? And then multiple specialties, right? So if there are multiple specialties involved, how do you handle that?
Yeah, well, maybe you can answer the question about what you do if it's not on site. I mean, certainly I think because of the pandemic, there's probably a lot of things that are happening now to normalize the way of approaching family. I was going to take the multiple specialty question because I think that often, like even this case, there are multiple specialties involved. One of the places in that video where I tensed up was in that final meeting where the lovely neurologist said, I didn't order that X-ray. She said it in a very supportive way. But that's one of the moments where I'm listening to see, is that a deflective tactic? But anyway, that's an aside. So the multiple specialties, I think it requires thinking through as a group, do you want everybody in the room? Or is there somebody who has a better relationship with the patient that would be able to represent the voice? But the thing that we don't do, I think, generally, because of how difficult it is, we don't often ask the patient who they want in the room. So the good example for this one might be an error that happens related to laboratory medicine or pathology. So this radiologist here said he doesn't have any patient-facing activity. Generally, pathologists might not have that either. And you might make the assumption that if there's a pathology error, that the person who's communicating with the patient should be the person who knows the patient the best and not invite the pathologist. And so I would say sometimes it's worth asking the patient who they would like to have in the meeting and taking the guidance from the patient when possible. But I know full well how hard that is to do. So I don't know what.
Just to get back to the first part, I think you're right that we've normalized having virtual meetings. And so we've done several of these over Zoom. And I actually think there's an advantage to that. Well, one is if you otherwise wouldn't have the meeting, there's a clear advantage for that. But two, it actually has allowed us to bring in the families to bring in family members that may have some healthcare experience or expertise who otherwise don't live nearby who could be part of it. I think that's been really helpful for them. And then I agree with what you're saying fully about the multi-specialty part of it. Not only I think ask the families, the patients for their perspective, but we found it really rewarding for our physicians to bring in those that don't really have any patient-facing activities. We've had pathology in the room, we've had radiology in the room, and they feel grateful for an opportunity where otherwise they barely ever talk to patients otherwise. We also sometimes have brought in, like in this case, we may even have brought in someone representing the emergency department, because even though there really isn't any fault per se from that part of it, we like the care to be represented by those that are providing the care. And so that allows them to speak for themselves and not somebody else to speak maybe for what happened to them. That allows also for additional questions to be answered if there are things that come up about that care. So I think it is perfectly reasonable to have representation from several specialties in the room. Again, as long as you're preparing ahead of time. And we've had times where we do one or two or even more pre-meetings to make sure that everybody's on the same page about that.
I just wanted to add one thing about the patient not being there. If it was a disclosure conversation, like it was the first time that you were telling them there was an error, and that needed to be done when they were in the facility, we have had some sites use Zoom to do that. But what we always say is that we want that patient to know they need to have a support person with them in the room. Because what the best practice would be to say, we have some important information we'd like to convey to you. Could you meet in the hospital and try to do that? If that was not possible, that is a sort of something else that we try to offer to them to say, this is something serious. We want you to have someone in the room with you in person. I think that we are out of time for this panel, but we will have some more time for questions after. We're going to move on to our care support presentation. So we'll just give us a minute to reset up for that. Thank you very much, panel. Thank
you so much for the opportunity to speak today. And I'm going to be talking about a term called care support. I'm curious as to whether or not anyone has heard that term before. But it's really been developed by the Betsy Lehman Center, and it's a term that's used to refer to what we might have historically called service recovery. The idea being that in the aftermath of an adverse event, our patients and their families can often be experiencing financial hardships, can often require care that they otherwise would not have required. And the whole point behind care support is to ensure that we're able to support those patients or their families during a really difficult time, and to try to alleviate some of the financial concerns that might be pressing secondary to the adverse event that they suffered. It's important for us to start thinking about when we might introduce the idea of offering care support. And at the organizations where I have the luxury and privilege of working, we often think of care support and offering care support at the time when we're having the initial discussions with the patients about what has gone wrong. as well as at the end of a review, if we actually identify, and this comes up not infrequently, occasionally at the end of a care conversation, we'll identify that while there was an unexpected outcome, it may not have been preventable. Or while there was an unexpected outcome, there was a very disrespectful or not dignified process or experience that the patient might have gone through during that entire time. And in those settings, again, we try to think about how we might be able to provide care support to those patients and their families as a very minimal gesture of goodwill. We always indicate that there's nothing that we can do and there's no financial compensation that we can provide that could make a disrespectful interaction feel any better. However, if it could be helpful to provide a bit of support financially around that we're open to that. As background, it's important for us to think about that this should really be offered in the immediate aftermath of an adverse event. Our patients and families are often most concerned about their immediate medical and social needs. And oftentimes that involves financial concerns and financial obligations that they're now going to have. Care support is assistance for patients and families who experience these unexpected adverse events. And again, it's really designed to provide financial support for care that would have otherwise not been needed. It is not intended to compensate the patient for their injuries. And I think that's a really important point here. We do not ever want to offer care support in lieu of or associated with a waiver of liability or the decision to not press charges moving forward, right? Like we want to make sure that we're reserving that right for our patients and their families, and again, trying to provide a little bit of support to get through this period. The support is given to aid our patients or family members during the short term, as I mentioned, and often it is funded by the organization. I think that's a bit of a nuanced point here, right? When we started this at the organizations that I work at, there wasn't exactly a coffer that one could tap into to offer this type of support. And initially when we started doing it, there was great concern where if we start down this road, are we going to open up the floodgates? And so it might have kind of started off with a ask for forgiveness versus permission process, where we just kind of started and, where we could offer gestures of goodwill. We ended up finding that the financial impact of this is like a rounding error for an hour at one of our large academic medical centers. When you look at the yearly totals, even in a big busy place, it just doesn't end up being extraordinary or what many of our more financially minded hospital leaders might be concerned about. There are various types of care support that one can provide. You can think about financial support, which is really what I've addressed so far, and there's also non-financial supports. Some are listed here. Sometimes when we talk to our patients, what they're really concerned about is transport. How am I going to get back and forth from the medical center, which can be unbelievably difficult to get back and forth from, and that can cause significant financial burden. Medical visit charges, that's another one. Now, we have to be careful here. There are many legal statutes and precedents that we want to ensure that we are not running afoul on. What does that mean? There are statutes, and I'll defer to the lawyers in the room to correct me if I say anything incorrect here, but there are anti-kickback statutes that have been filed into the legislature that make sure that hospitals cannot induce a patient to get services in their organization and then bill our federal government, right? We don't want there to ever be, heaven forbid, the perception that, in fact, what we've done here is encourage people to come for additional services and to our organization in the aftermath of an adverse event. So to really prevent against that, what we often do is say and document, we want to support you during the aftermath of this event. To that end, whether you choose to come to us for your subsequent care or elsewhere, please stay in touch with our family advocates or our patient family relations representatives, and we can try to assist in any way that might be beneficial to you. There are other things like meals, fees to obtain medical records, childcare expenses, even sometimes medical devices and monitoring that might be required, all of which can be considered. And I'll tell you, the list goes on. We do take a very patient-centered approach where we will ask the patient after, and again, the timing of these conversations is important. And we need to make sure we're not tone deaf as we're having these conversations, like when to have these conversations. You take your cues from the patient. But when you're having these conversations, I really like the patients to drive them. I will say that there was the aftermath of an adverse event, and it was a few months later, and we had a request to pay for online dating services. It's a tough one to say yes to, right? Like, we truly do try to delight the patients with what they ask for, and we try to have a just say yes philosophy. We were able to redirect the conversation, and we were able to help with some other things, but not the. It was an interesting link, though. She's like, you know, her impression was my relationship failed secondary to this adverse event, and I'm going to need to give dating services as a result. So a little bit unorthodox, but we're continuing down, you know, working with our insurer, and so hopefully we'll talk more about that later. Non-financial support, you know, everything from facilitating appointments, accessing community-based healthcare, as well as offering our patients and families any engagement opportunities. I've been amazed at the degree of error suffered and the degree of willingness to stay within our community and help others. And oftentimes that offer of, would you like to help other patients? Would you like to participate in our patient family advisory councils is met with acceptance. It could be because sometimes the time it takes to have these resolution conversations can be pretty protracted, and folks have a little bit of distance from the error, and they're at a place where they're really just wanting to help, which is lovely. Some really important additional conversations or considerations that I don't want to belabor, but I do definitely want to mention. Documentation is really important in this regard. We want to make sure that we're documenting why we're providing whatever type of financial or non-financial assistance we're providing. We know that we're doing this for all the right, true north intentions, and heaven forbid anything get misrepresented or misinterpreted. We want to make sure that our documentation is tight and our intentions are clearly outlined. So we just kind of outlined a few points here. There's also a lot of legal implications. I mentioned some of this, right? We never want this offer, the support to be considered any type of inducement. It's really important to have clear internal guidelines for how and when care support funds are used, and that we're documenting why that support is being offered. From a guiding principles standpoint, important, and what we do at our organizations is have conversations and review these cases with a multidisciplinary team. That multidisciplinary team reviews members from billing compliance. It includes our risk management team, it includes our patient safety specialists, various other groups across our patient family relations team members, various really groups across the organization to think about the case and make sure that we're having really thoughtful conversations about when we are and are not supporting our patients. It's important to make sure that in every case we review the system contributors, any performance contributors, and behavior contributors to the risks that we're seeing, and making sure that we're continually learning from all of the events that we're seeing. That's so core to the work that we do here. And engaging with the patients in this way is often an opportunity to bring in another lens. Oftentimes the patients will tell us about risks that our analysis within the organization would not have identified. So again, staying in touch and connected with the patients while we're offering care support can often help with that. I will say that if the dollar ask is nominal, we really do try to have a just say yes philosophy with some bookends as described a little bit earlier. Always documenting the rationale. ensuring that anytime that there is some care support provided, especially financially, that the patients do understand the clinical implications of the care that they received, and that equity is at the forefront of every decision we make. This is something that can be a little bit uncomfortable for folks to really kind of settle into, but I personally believe it is okay and equitable to make a different decision for the amount of support that's being provided for a patient of lower socioeconomic status, secondary to the needs that they might have. That took a long time to get folks comfortable with because it wasn't there. And I think that if we think about equality versus equity and equality a bit differently, I think that's an important nuance, but a hard one, definitely a hard piece. I do want to go over just a few examples of how this is used in real life because it kind of just seems like high level right now. So here's an example, a patient, and I'm curious as to whether or not any of you have had these types of cases in your organizations, who struggles with homelessness, white, Hispanic, non-English speaking, and experiences a dental injury during extubation. Case review is completed and case analysis completed with an evaluation of system performance and behavior. But before that's completed, there's a need to have some support for the patient in the immediate aftermath. Our process is to apologize for the experience, and some of the language that was used today was beautiful, and offer support for the needed reconstructive services. Now, we do have up to a limit that we usually suggest, and it's a just say yes. And then above that, we review the case of that multidisciplinary group. An important nuance here is the care doesn't have to be delivered by us or by our dental group, right? Anywhere the patient wants to go, we get an estimate, and then we try to do what we can when cases are appropriate. We share the finding with the patient and the family, as always, explain what we're doing to try to prevent this from happening in the future, and then we document. Question for all of you, I don't know if this is okay to do participation, but there was a time when during the anesthesia review of the case pre-surgery, if a patient was identified as having poor dentition, that these policies didn't apply. Because it's more likely to have a dental injury, right? I really stepped back and thought about that. It didn't really feel like it took the equity lens that we wanted to. Now again, this is highly nuanced. This is super highly nuanced. But where we're able to offer this type of support and where it's appropriate, it does tend to make sense. And we've had great response with it. Another case, 67-year-old Black English-speaking private pay out-of-state day surgery patient who has unexpected post-op bleeding requiring an overnight stay for observation and requests a private room in the super fancy pavilion suite, which is thousands of dollars per night. Don't know why, but for me, this one is tougher than the dental injury one. I don't know, and I have to acknowledge my biases there, but there's probably something that I haven't exactly figured out therapy yet behind all of that. But to that end, if we apply these principles, we apologize, get the review of the case, offer support for the unanticipated night. If it is possible with our census and everything else, we try to do what we can to meet the patients where they're at. I'll bet these are trickier for me to really wrap my head around. Share findings once we identify the review, and then make sure that we do some limit setting with those conversations as well. And then finally, the last case that I'll go over is a patient that is 76-year-old male, white, English speaking, presents with 40-pound weight loss. This is your classic delayed diagnosis case. And in this case, again, during the scenario that we just saw, there was an offer and a need for that patient to maybe have some in-home services for a loved one, that would be the type of care support that we would consider. Again, it would be really hard. It would be a lot of discussions. We'd have to really understand what the financial implications are, but where possible, trying to offer that type of support during a critical time. And again, we have explicit conversations about time binding some of these services and what we're able to help with. To that end, I think that we're pretty much wrapping up. This is just an overview and summary of kind of the three big principles, right? Implementing reliable systems, making sure that we're overcoming some of the challenges that are associated with these programs, and hopefully resulting in systems that allow for a kindness first approach during some of the most difficult times. So with that, I think
great, thanks so much, Karen. We're going to have a panel about this topic right now, so I'm just going to get this set up really quickly. And Barbara is going to moderate.
Okay, so first of all, Karen, thank you so much for that presentation. And so what we have, what we're going to do now with this themed panel is really so reflect on what Karen just discussed and hear about how three different institutions approach care support. So just very, very quickly, you have them on your agenda, and I know we're short on time, so I mean they have wonderful libraries, but just the basics here. So Beth Jackson is Senior Risk Manager at Tufts Medical Center. Elise, who is doing double duty on panel today, is the Care Program Manager for Baystate Health, and Megan Colazzo is the Chief Compliance and Privacy Officer at the IDMC. Okay, so with that background, so several different perspectives. So so this could be kind of rapid fire because we don't have much time, but for Beth and then for Elise, you heard Karen's presentation about how specifically the Brigham has approached care support. Can you tell us some of the just the similarities and differences on how your organization approach care support? So why don't we start with that?
Sure. Thank you very much. I'm Beth Jackson from Tufts Medical Center. Tufts Medical Center is under the umbrella organization of Tufts Medicine, which includes Lowell General and Melrose Wakefield. Thank you, Karen, for your presentation. Your case studies were great, and I believe at Tufts we would handle cases like that very similarly. What's different at Tufts Medicine is we have a captive insurance company, so we might be a little more nimble than others. We do have a policy in place about grievances and cases that meet care criteria. And also at Tufts, we are a little on the conservative side. So we would really analyze what we were offering. It's rare and infrequent where we actually pay for some of the additional costs, but it's really, as you know, our business is not cookie cutter. We have to evaluate each case individually. We do hold bills and retract claims where appropriate, but Tufts does take a very conservative approach.
Thank you, and we.
Thank you. So we follow pretty much the same pattern, similar to what Beth had outlined. We do look at cases more need-based. So certainly if someone had an inpatient stay and maybe lost their dentures, then it's a Medicare patient, and we want to make sure that this person is made whole before they're discharged. So more immediate needs we definitely want to meet. I would also say that we can be nimble and we don't have the coffers explicitly set up, but I will say that we have an amazing leadership, and we want to engage our leaders when we have an opportunity to say we've got this case, we need to talk about it, and we'll bring our leaders in and have those conversations. I would also like to say that when we start the care process, every contact with the patient and family is an opportunity to learn more. So sometimes we can reach some of those non-compensatory offers or exchanges, and you know, we really want to make sure that we're supporting them, and that's most important in those early moments.
Great, thank you. So my next question, I'm going to direct to Karen, Beth, and Elizabeth. So Karen, why don't we turn to you first, and the others can think about this. So is there a difference? I imagine there's situations where what a patient or family member needs is kind of a single support mechanism at one point in time versus support that could extend for a long time depending on the situation. So how do you handle the situations differently?
That's such a great question. It really, really is. And I have to tip my cap to the phenomenal teams within our patient-family relations group. They are the key contacts between the patient and the organization, and they are able to have such nuanced, brilliant conversations with the patients that really help allow for, we really want to help and here are the boundaries to that. Now, again, nothing would make me happier than if some philanthropic sponsor decided to overflow all the coffers, which the coffers are not overflowing these days, as we all know. Nothing would make us more happy, but we have to really be judicious about the opportunities that we have. And therefore, I'll say that the emotional intelligence and the emotional IQ of our PFR teams is exceptional and often able to help make patients feel good about what we're offering and ensure that there are really healthy, gentle boundaries set. I hope that answers the question.
Yeah, thank you. So, Elise, why don't we turn to you? So the difference between how do you deal with short-term versus long-term use?
Sure. So again, a case-by-case analysis on how we manage those cases. Being a captive, we do have the benefit of having our claims department in-house. So we certainly want to reach out and bring them in. If we're discussing a never event, then we perhaps can have a wider conversation in that respect. In the more short term, again, we want to learn as much as we can about the family's needs and where their concerns lie. But when we don't have that answer, I always fall back on let's continue the conversation. Let me take this back to my team and let your moral compass, your internal compass guide you in that conversation, because if this is something that really needs to be advanced, then we absolutely want to do that.
And I would agree with Elise as well. For short term, we really lean on our patient relations team. And for more long term, our claims team is also in-house and they would handle long term.
Great. So Megan, we haven't forgotten about you. You play a different you play a different role in your organization. So which gives me the opportunity to ask about compliance concerns when it comes to care support. And Karen, in your presentation, mentioned the kickback laws, other concerns. So tell us what some of those concerns are and how you've addressed those.
Sure. So Karen took the word out in her presentation. From a compliance perspective, some of the things that we do think about are, it appearing that, we are inducing patients, but that we are, tripping referrals to certain providers and to maintain that care. That is certainly not the intent of these programs. So at Beth Israel, I work closely with our legal teams, our risk managers, we've developed a program where that intent is documented. That's really the key piece of this. And, there's documentation at various levels. There's documentation of the general process. for, the review of these types of cases, thresholds that may be in place as it relates to the service recovery payments, but then also at the patient. So when there is a determination that, we are going to provide some services, we're documenting that in the patient file, the intent. And I think the example was out there, providing transportation to allow for ease of access to care following this event, making sure that that's documented at each individual patient level is very, very important. Because when folks get into trouble with the anti-kickback and civil monetary penalty law, it's really, if there's no intent there, then, you're likely not facing, violations. So document is really what I want to hammer home. Because again, these programs are wonderful and I think are very beneficial to the patients and we just need to, have the structure in place that will support that from, both the state and government perspective.
Just a quick follow-up to that. So do you have any words of wisdom for hospitals, systems that are thinking about, or they're at the beginning, or thinking about how to implement care support? So almost like lessons on what would you do? Where should they go? Where should they go?
Yeah, I mean, I think, having the internal conversations, I think a lot of organizations are very conservative. And so they have not wanted to sort of go down this path of creating these programs because they assume that the answer is no for all of the reasons that I just said. So I think it's really, approaching the subject and making sure that you're involving the right people in the room. And having a subject matter expert that, understands the locality and some of the ramifications. And then, building a program from there. I don't know if I answered your question.
That's helpful, and we will have an opportunity for more questions, and I'm sure people will have more questions about that. So I have one, so the final question for all of you, and really around what, are there voices that we still need to hear from on this issue that we're not hearing, and who are we missing? And while you're thinking about that, I also want to just draw everyone's attention in the room. In the very back page of your packet are some guiding principles for care support that have been developed. They are also available on the website. And so for those of you who are remote, we will drop the link into
it's part of the packet of materials that's in the chat.
So it is part of the packet, the virtual packet of materials that you have received. So okay, so why don't we go? I'll start in this end with you. You want to start at that end? Oh, from the let's start at that end.
Can you repeat the question?
Sure. My version into So I got lost. Finally, just for everyone. So it's just what voices are missing? Who do we still need to hear from?
I mean, I think your patient relations, your quality folks. I also think, if your organization has like an ethics officer, I think that's someone that is key to these conversations.
I love all those examples. I'd also encourage patient family advisory councils. So I think that's unbelievably important. I think that peer supporters too, to be honest, because oftentimes in the aftermath of the bad events, when we're talking to providers, they're like, they just need this right now. Can we just do that? So making sure that the peer supporters know or not, if that's possible, I think it's helpful. Of course, the patients, right? Like super critical, and probably the chief diversity, or if you have a D&I group, to again just help with the thinking around how to think about equality and equity.
So I think that another group that we tend to, I don't want to say overlook, but we really need to engage in is our billing operations. And I love that Karen's presentation did mention that. Talk to your billing department, your accounting, finance department, on both fronts. Do we have any opportunity to make a small budget here? And what can we do and bring in that small group, have a huddle if it's a concerning case that you want to be able to see what your options and what your resources are. So I would recommend also engaging them as well. They'll also probably give you some good guidance on, documentation, because they're probably going to need some documentation if you're going to be, modifying their bill or adjusting in any way as well. So,
those are all great suggestions. I like Megan's idea of ethics. I don't think we've thought of that one. Also, social work is key for looping in for additional resources and support that the patients and families may need.
Great. All right. Well, thank you. So I think we have some time for questions. Do we want to go in the room? I see one hand, and are there any? There may be some online.
I was curious, as other panelists had mentioned, a lot of situations are not as simple as this case, in the fact that, like, I can think of plenty of patients who went to one ER, then went to another ER, and then go to the specialist in a different hospital than their own primary care to finally deal with the concern. So I was curious on how, like, do the hospitals work together, or ultimately the first hospital who may have made the mistake kind of have to handle, and do they work with the hospital that the patient's actually getting the treatment? I'm just curious in situations like that, because it's, especially in our area, when we're saturated with hospital choices. So.
Yeah, that is a fantastic question, and super nuanced and really dependent upon the various different organizations. One of the things that's amazing about the Betsy Lehman Center and these types of forums is we get to know each other. So if tomorrow something happens, like we pick up the phone and we call and we try to figure out how to best support the patient. It's not a straight answer at all, and it's highly dependent upon the various different organizations. The things may or may not have happened. Again, from a purely true north perspective, if there's a patient that is struggling and vulnerable and there's something that we can do to help, I think that's what we're there to do, regardless of where the sharp end might have been. But it's hard. And none of this stuff is easy.
Yeah, and I'll also just say to that, I think what you pointed to is an issue that we've identified as a gap. I mean, as I don't have to tell you, medical care these days, the team sport, there are a lot of transitions of care. There's a case that came to our attention of a delayed diagnosis of breast cancer involving a primary care office unaffiliated with any hospital, a independent imaging center, hospital. I mean, so how do you, and with a hospital and a patient that would have really wanted to engage in this kind of a conversation, and how do you do that? I mean, and so that's something I think we still need to work on. If we need a policy response to that, we need collaboration with liability carriers and a lot of sort of cross institutional. So I think there's no short term answer to that, but that's something that we're increasingly seeing. It's many, it's oftentimes a lot of people have been involved in these situations.
One question from someone attending online. Is there a disclaimer or supporting documentation given to the patients and families when you're offering this kind of support to reiterate it's not compensation for an injury and to emphasize the rationale you described?
No, we don't. I mean, the conversations are generally, they're conversations. And we discuss that we will be very explicit that it is not in lieu of, you do not have to sign a waiver. This is not in lieu of pursuing a claim or a malpractice claim down the line, but there's no formal documentation.
That's good.
Anyone else in the room have any questions? Thank you.
Thank you. Thank you. Thanks very much.
Okay, next on our agenda is the provider testimonial. So our testimonial comes from Dr. Walter Kilpatrick. He's the director of Psychiatry Consult Services at Baystate. And he has a wonderful testimonial to share with us today. This also will be available online later in case you want to show it to any providers who don't know about this program. So we're going to watch that together now.
My name is Dr. J. Kilpatrick, and I work at Baystate Medical Center, and I'm the director of the Psychiatry Consultation Services here. So this was my first time being involved in the CARE program, and it was a very positive experience. I think like most providers, when they learn they may be involved in a program, there may be some anxiety involved. And I think that's pretty normal. But as you get to learn more about the program and its purpose, that anxiety ultimately dissipates. And there's tremendous potential to have it be a positive experience for both the provider and the families involved. One of the aspects of the CARE meetings that I think could be universal are that there may be very strong feelings, emotions, and affect, certainly that may come from the family. And I think that may be something that providers may get anxious when thinking about, or there may be some fear around that. What I realize is the strong feelings in the room that you may see in the meeting are actually an opportunity to engage further with the family. And while your body may be saying to lean back, what you actually want to do in those moments is lean in. And you want to explore that more with the family. And the family may often open with that. And this is what occurred in the meeting I participated in. And what you can do in those moments is invite them to say more. You can validate the feelings. It sounds like your family has been going through so much. Can you help us understand what you've been going through more? And it gives them a chance to get that out. And it also proves to them that you are listening and that you are curious about what they've been going through, and that you want to understand it and empathize with them. And that is a really good way to form an alliance in the meeting with the family. That ended up being a really nice approach because they told us more. And when they were done, you could see a change in the room. They had the opportunity to get that out. And then once that happens and they're able to think more, they're able to be a little more cognitive. So you move them from a place of high emotions to a place where they can think more and ask their questions. That is when the opportunity is there to help explain what happened from a medical standpoint, mental health standpoint. And then everyone is talking, okay? And I think that is sort of the goal of many of these meetings. They won't all go like that, but I think it's the goal of many of these meetings to move the family from a place of either high emotions or high cognition back to the middle. And then conversations can occur. As providers, we are often heartbroken when an outcome is undesirable. It could be a loss of life, a change in a mental status for a patient. And for the people sitting across from you, it's their family member, their loved one. There is actually typically shared loss in the room. Now, obviously, we want to keep the families at the forefront of the discussion. But I think what providers may not realize is that they may be suffering too. And there may be an opportunity for healing between the family and the provider. One way to do that is actually to ask the family, after you've spoken to them for a little bit, we only saw your family member in the hospital. Can you tell me, what were they like outside of the hospital? You know, what did they like to do? What did they enjoy? What were their hobbies? We had a moment like that in our care meeting, and the families really lit up. And we got to hear about the patients, what brought them joy and their hobbies, and we got to share that. And it was really a moment of healing for I think both parties involved. That's another nice way to make a connection. I'd recommend it. Asking more, telling them we only got to see them when they were sick. You know, what were they like when they were feeling better? What did they enjoy? What did they like to do? You know, another thing we can do is ask about family members who aren't in the room. You know, if there were extended family you knew that were involved too, and were maybe visiting or whatnot, you know, I would invite the providers to ask on how the extended family are doing too. The families involved, I think, would really appreciate that. And it's another way to form an alliance with them. But make no mistake about it, both parties are definitely suffering in this moment. It's our job to answer questions for the family. We can do that compassionately and empathically, and it's okay to acknowledge that this is very hard on the providers too, and that they're going through something as well. And that is one of, I think that's some of the magic that comes out of the care meeting, is that the provider can actually leave the meeting feeling better. Even though there's been a loss of life or a tragic event, there can be a lot of healing that goes on for both parties in this meeting. There will certainly be times in a care meeting where a family may be so upset or distraught that they are in that moment inconsolable. It is okay to pause the meeting. It is okay to say, I want to figure out the best way that I can help you right now. But there are a lot of feelings in the room right now, and that's okay. That's why we're here. And I'd recommend we take a short break and come back. This way I have some time to think, and we can come back to the table and discuss this more. You can thank them for expressing how they're feeling. Tell them I need to take a break for a moment because I need to figure out how best to help you. And when voices are raised, it is hard for me to think in that moment. And if I can't think, I can't help you. And that's why we're here. You can also posture that question to them. I can tell how upset you are. I can see that you're suffering and that you're having trouble even engaging in conversation with us. Please help me understand how best I can help you right now. Tell me what you need right now in this meeting, and we will do whatever we can to meet that need. It's okay to pause to do that. Give them a break, water, food. These are wonderful gestures, if possible, to have at the meeting. But it is okay to pause and regroup and come back. In fact, it's healthy. And they may need a break too if they've just let go of a tremendous amount of feelings. So the things that may make you very fearful of the meeting are actually the opportunities and the tools to have the meeting go really well. If you have a lot of feelings in the meeting, it's a good thing. It means the meeting's probably going to go well. You just have to lean into them. Allow the family to go through that. Be curious with them. Invite them to express more. Then you can get to the questions, the nuanced medical piece. The facts of the case can be difficult for families to understand, even the most sophisticated ones, which was the case with the care case that I was involved with. One thing you can do is take a position of curiosity and invite the family to identify their needs. And in this scenario, that may very specifically be, help me understand very specifically what question you need answered. And you may have to do that one question at a time. Check back in with them after you answer. Did what I say make sense? We're explaining a very complicated procedure, or we're explaining a very complicated laboratory panel, okay? And a cascade of events that brought us here, okay? So continue to be curious, continue to check in for these very specific detailed-oriented questions, and reflect back. I see you nodding your head. Did you understand? Do you feel like you understand? Do you feel like I answered the question in a way that is understandable? Did you feel like I answered the question in a way so that now you have a better sense of what happened specifically? Take that position of curiosity and continue to ask if you were able to answer the question. And what you're actually doing is encouraging the family to get their needs met. And that is really key in helping them to feel heard during the meeting and feel like they're getting the information they need. Chances are, if you're really sort of enmeshed in the discussion, you may feel a little tired after. But it's one of those tired's where you know you did the right thing. And you did the right thing for yourself, for the patient, for the family most importantly, and even Baystate Medical Center. One of the benefits of having a meeting like this was it provided some closure to the case. Now that may not be true for every case, and there may be some cases that continue afterwards. But as a provider, I knew without the program, there would have been this event and it would have been out there, and I would have never really had closure with it or a connection with the family and had any or gained any sort of meaning to the event. And this program allows for communication, it allows for healing to occur, it allows for a process to get feelings out. And ultimately, I think it allows for some closure, potentially for the family and the provider.
That's a tough act to follow. So I get to make the closing remarks and, on the 10th anniversary of the first care forum. I hope you'll forgive me if I get a little sort of wistful and think back on the history. Pat and I were just talking about how quickly 10 years went. And the folks here in the room and the folks who are in hospitals in Massachusetts on the virtual platform who've been doing the hard work for years and years, we're the choir. And I just want to step back a bit and one of the things that this meeting is for me every year is an inspiration to go back and do more and to do better and to get this right. So we stand here 10 years on, and really it's 15 years on, on the shoulders of giants. Alan Woodward is on, Evan Benjamin, Pat Pocarelli is one of the giants, and Ken Sands, and there are many others. And they started this at a time where the things we've heard about today, what Karen is doing with her team at the Brigham, there's no chance that could have happened. So beyond those giants, there's been a whole lot of you who have worked really hard on what I consider a movement. And it's just so heartening to see that movement continue to grow. We're the choir, and the choir keeps getting bigger and bigger. And that's because of other really special people, all of you, but I think of the heart and soul movement as Melinda. There was not a question today that anyone could have thrown at her that she wouldn't have handled perfectly. I was really impressed by that first series of questions you handled. And I'm also impressed that every single year I come back to this forum and we learn more and more where we're falling short of the ideal program. It doesn't matter how good we think we've got it, how great we think we're doing. Then we get together when that happens and we come up with tests of change. We produce new resources every time and we get a little bit closer to that idea. And I just want to reflect a bit on the movement. To think 10 years ago, 15 years ago, that this would be written into the roadmap to patient safety for the state of Massachusetts, to think that the candor program would be promoted across the country, to think that Peter Smolowitz would have been at Beta Healthcare last week, the malpractice insurer for all the UC hospitals in California, and addressing a group that started as about 20 hospitals, but now I think maybe 50 or more, who are just like us, trying to figure out how to do this right. And by the way, learning from us. To think that the PACT Collaborative was started and that people from our collaborative are the teachers. They're spreading what we've learned throughout the whole country. And to think that just 1 year ago or so, the group here in Boston won a HRQ Centers of Diagnostic Excellence grant. That grant is being led by Gordy Schiff, who's on the call. Hi, Gordy. And Tom Gallagher, who's Noel Lauga, Sokol Hessner from us. Lauga's on the call as well. And the case that we saw today, because the ED doctor noticed that something happened before. To think 10 years ago that some organization and some funder is funding Gordy to go back in time and actively search out missed and delayed diagnoses of cancer we don't even know about today, and then work with Karen and the team to no matter if it's 10 years ago, 15 years ago, 3 years ago, have the conversation and do the right thing by that patient is pretty amazing. It's pretty amazing. So I can't wait to take part in 10 more of these with all of you and to see what we're going to learn this year and what we're going to hear about next year that we learn is keeping us a little bit further away from that ideal program. And I just want to thank all of you so much for the work you've done and for pushing this movement as far as it's gone. Thank you.